Hello and welcome to the Doctor's Inn. I'm Marcia Boyles, and as always I am accompanied here this morning by Dr. Kamaljit Sethi from the Medical Center. Before I introduce our guest, Dr. Sethi, I think we should acknowledge the fact that this is the beginning of our second year in this program. We started in August of last year.
Yes, indeed. And thank you so much, Marcia, and to all of the staff here at Channel 6 for assisting us in putting the program on. We leave the success of it to our viewers to tell us what they think.
Yes, exactly. And thank our viewers, too. We've certainly had many comments from folks that have been very helpful. So I agree with you. Now, this morning we are delighted to have a guest who is a nurse practitioner at the Medical Center, Cavetta Green. And Dr. Sethi, you will talk a little bit about nurse practitioners, and Cavetta, you will as well. We're going to ask you a bit about yourself, where you went to nursing school, where you have come from. So, Dr. Sethi, I'll turn it over to you.
Okay. So, first of all, welcome, Cavetta.
Thank you.
And we hope that there'll be other times that you'll be able to come, and some of our other nurse practitioners who work with us will be able to come, and we have several. And I truly think that the way to optimize medical care is to ensure that we have an appropriate mix and diversity of the types of providers we have. And so it's very good to have nurse practitioners. I myself have worked with nurse practitioners for many, many years. And this is essentially, Marcia, for our viewers, because Cavetta, of course, knows this, that in most states in the country, including in what is called DMV, the District of Columbia, Maryland, and Virginia, in DC at least, I know for sure that nurse practitioners are what are called LIPS, Licensed Independent Practitioners. And that means that they can do everything that physicians can do. And so what we need to do as the public is to place our trust in all the providers that treat us, so that we think that while the functional level may be slightly different, that they can function independently of physicians. So if Cavetta, for instance, you were in the district, you could have a practice of your own and seeing patients. And so we need to really accord that same level of deference and place the same level of trust in our nurse practitioners that, you know, we do in physicians. So we thank you very much for being here today.
Thank you for inviting me.
So tell us a little about yourself.
Okay, so I actually got my nursing degree in Arizona at the University of Arizona. After that, I worked at a hospital there in an ICU for 7 years, and that's when I decided I wanted to go and get my MP. So I actually did it here at GW.
At GW?
At GW, and got my master's there, yeah.
I first met you over at Garden Ridge, so I know you also work over there.
I do,
yeah. And was always delighted to have you. You were excellent.
Thank you.
Now, our topic today is constipation.
Yes, indeed. And you know, I find that generally folks are a little squeamish about talking about some types of problems which pertain to certain anatomical regions. And to be more direct, we are a little bit squeamish talking about the urinary tract, you know, and the GI tract in some parts. And, you know, we ought not to be that way, in short, because all parts of the body are important for the functioning as a whole. And so constipation, because it is part of the a symptom that is related to what's happening in the GI tract, we need to think about constipation in the same way that we would about any other problem. It's certainly a very common problem, particularly for our demographic.
It becomes more frequent in aging.
Yes, it does. And we're going to talk more about that later. But it might be useful at the beginning because we use the word sort of loosely, and it's unclear when someone says, I have constipation, what they actually mean. So for clarification, usually constipation means having less than 3 bowel movements a week. If this happens over a period of weeks and months, then it's called chronic constipation. So to expand on this definition, there are some additional factors that may convey. So for instance, if the stools are hard or lumpy, or if you have to strain, then those would be the kind of things that would count towards constipation. And if you have a couple of those symptoms and you have infrequent bowel movements, then that would put it into the category of being chronic constipation. So we need everybody to know that. So if you haven't had a bowel movement one day, that is not constipation. What we also wanted to do, as we talked about this subject and we discussed this between ourselves, is to identify what we hope people will take away from today's program, and then we'll circle back to it at the end. So we wanted everybody to be clear about the definition, first and foremost. Secondly, what can we do to prevent it? So before you ever get to the point where you think you need medical help, what should you have done to help yourself, right? And then lastly, when should you consider going to the doctor for constipation? So those are the 3 areas that we're going to focus on. So having said that, I think that it's appropriate for us to talk about being sure we know the definition, which we've already identified. And then the next question that always comes up when we have a problem is, why does it occur? So constipation is like a lot of other things in medicine, which we can't actually find the cause and say, aha, this is it. This is why you have constipation. You do this and it's gone. We can't really say that because it's a problem that may recur. So speaking in broad terms, anything that blocks the GI tract, for instance, can cause constipation. I don't want to dwell on that because the most serious amongst those problems would be, say, colon cancer. So colon cancer certainly occurs. It's a common cancer, but it's not the primary reason why people get constipation. So I don't want anybody to listen to us today and think they need screening for colon cancer, right? They might otherwise. The second problem could be, and this occurs in some special medical conditions, if there's problems with the nerves. So that means just like, you can have neuropathy when you have tingling and numbness in the legs, you can have some neuropathy in the GI tract, more likely to occur, for instance, in those who are diabetic, or, if you have something like Parkinson's, that can cause more constipation as well. Difficulties, muscular problems, for example, multiple sclerosis. That could be one of the problems associated with constipation. And then some hormonal conditions. So for instance, those who may have severe hypothyroidism. So again, to put it into perspective, having low functioning thyroid is common, but having constipation due to that is uncommon because we're very good at treating it. So those are some common reasons why it may occur, but none of those are primary reasons why constipation occurs. It's usually just things moving very slowly in the gut, slow transit. So, we may not find the cause, but, we are very effective at telling you what you can do to prevent it and then obviously to treat it, So there are many risks, of course, many risk factors that can cause constipation to occur. And Cavetta, I know that you discuss this often with our patients at the medical center as well as at Garden Ridge. So maybe we should talk about that.
Yeah, absolutely. So there's a few things that put you at higher risk of constipation. One of those is fluid intake. It's really important to take in enough fluid, water in particular, to ensure that there's enough moisture in there to keep the stool moving.
And does actually drinking more water sometimes really solve the problem or help
It helps.
solve it?
Like Dr. Sethi said, there's not, it's usually multifactorial. But like I said, just in general, to allow the stool to actually form and to allow it to actually move through the gut, you will need some fluid for that.
Okay.
Also, if you don't have enough fiber intake. You know, we hear people talk about fiber all the time. It's an element found in particularly fruits, vegetables, and grains. There's a couple different kinds of fiber that you can use, both dietary and supplements. But if you don't have enough fiber, you're not able to really build bulk, right? So that what you see in your bathroom, in order to form that, you're going to need some substance to it. And fiber helps to form that substance so that it can, again, keep moving through. Another risk factor is if you're not very active. Exercise really helps to promote movement and activity of the gut in general and of those muscles. So again, it's all about transit and getting what's in there out. And so having those muscles be active helps to promote that. And another big risk factor, especially for an older age group, is the medications that you take. There are a lot of medication classes that can promote slowing of the bowels and slowing of the gut. And the particular ones of importance, I think, for us are opioids, iron supplements, which a lot of people are taking, and also antidepressants. All of those can slow down the gut.
Okay. And by slowing down the gut, you mean the actual muscles, contracting muscles of the GI tract?
Yes. Yes.
Now, this may sound repetitious, but at the risk of doing so, we are going to talk about this again when we talk about how can you prevent constipation. Because obviously, if we address the risk factors, then we can prevent it. So we'll talk more about this as we move forward, and some precautions as well for certain individuals who've got certain medical conditions. So we'll be talking more about that as we go further.
Yeah.
But, you know, as you rightly said, ensuring that there's enough activity is really important. So each individual has to see what their exercise capabilities are. And if nothing else, walking, even sitting in a chair and doing exercises rather than lying down are preferable.
And the other small caveat too with fluid intake, you know, of course there's going to be those with medical conditions that preclude them from, you know, drinking tons and tons of water.
Yes.
You know, heart failure, or let's say you're someone who has a low sodium level, and that's something that you're treating. So those things you have to be careful, but for the most part, you know, we do want you to make sure you're having enough fluid during the day.
Yeah, that's a kind of simple solution for a lot of people, I would think.
So if constipation becomes chronic, this won't happen with a single episode of constipation related to whatever acute problem may be occurring. But certainly if this is chronic, there are some problems that can occur as a consequence of constipation. Generally, they are not very serious conditions. Exceptionally, they can be. So let's talk about common things. So if somebody is straining a lot and the stool is always lumpy and hard, that can cause hemorrhoids to form. And hemorrhoids may be internal or external, but hemorrhoids can become, and if they're pre-existing, they can get worse and cause bleeding. So we see a fair amount of rectal bleeding occurring. And so when that happens and you see bright red blood, the first question you have to ask is, do you have hemorrhoids and do you have constipation? Because that's at least a way to identify the cause of the problem. The second thing that can happen is that when the stool becomes hard enough, and sometimes individuals will describe it as being rock-like, then it can get impacted, which basically means it can get stuck. And if the stool gets stuck or impacted, then it has to be loosened up. And so that may require, you know, specific treatment like enemas or disimpaction to get it moving. When the problem persists chronically over months and years, particularly as folks get older, there may be what is called prolapse, which simply means that a part of the rectum, because of continual straining, the walls get weakened and some of the rectum may actually come out of the body and be visible.
Really?
Yes, and it does occur. We've had folks who've had that problem, and so we want to obviously avoid constipation in that setting. But sometimes surgical intervention is also necessary because it becomes so bothersome to the individual. In and of itself, there's nothing risky about it, but it's just very uncomfortable for people, and they generally want it treated. I've sometimes seen folks in their 90s want to get treatment for it, surgical treatment, you know. So fortunately, for the most part, those complications are treatable. We never want to get it to the point where there's prolapse. We want to catch it much sooner, you know, and be attentive. So since we've been talking about, you know, the risk factors, this may be a good time for us to turn to what can we do to prevent constipation.
Absolutely. So a lot of it is kind of mitigating, preventing those risk factors, or figuring out how to get around those. So one thing is with diet. You definitely want to increase your fiber intake if you can. And again, fiber is found in fruits, veggies, and grains, but in particular certain ones. Apples are a great source. Prunes, of course. Certain nuts, almonds, peanuts, peas in particular. All those are extra good sources of fiber. Beans, very good sources of fiber in food. You can also try supplements too, Citracel, Fibercon, those types of things. If you're going to take a supplement, and even with food sources of fiber, you do want to be careful to, again, make sure you're getting enough fluid intake, because the goal of those, again, is to help build bulk, but you also want that moisture to help. You don't want to form this gigantic mass that then you don't have enough fluid to help pass, because then that's not helping you. And you also want to avoid foods, if it becomes a problem with constipation, you do want to avoid foods that are constipating, cheese and dairy being two particular culprits. So you might want to go easy on those. Again, you want to increase your exercise, and it's whatever you can tolerate. Like Dr. Sethi said, walking is great. Whatever you can tolerate in the bed, you know, is great to help keep things moving. We talked about the fluid intake and the dairy. And another thing you can do too is, if you feel the urge to go, listen to that. You know, don't hold it, don't wait. If you can, get right to some place, you know, and try to go. Don't ignore that urge. And then the last thing too is to try and keep a regular schedule. It's really important. Let's say you know that breakfast is your biggest meal of the day. Set aside maybe 20-30 minutes after that. Take some time and try to do that, and try to help train your body to get on a schedule so that it knows it's time to do this thing, and that can help.
Those all sound like such good practical kinds of things that everybody can do.
Absolutely, absolutely. And I will put in one last plug, because we did talk about one of the risk factors for constipation being medications that you take.
Yes.
And I did want to speak particularly to opiates. You know, your Vicodins, your Percocets, hydrocodone, those kinds of medications. If for whatever reason you do find that you need to take those for chronic pain, or if you've had, say, some kind of surgery, a hip surgery, a shoulder surgery, and you need to take those for any amount of time, we would actually recommend that you go ahead and take a stool softener proactively, because those can be devastatingly constipating.
Yes, I think anybody that's ever taken them is very aware of that.
Yeah.
Right.
Yeah.
Right. So I think that, as we said earlier, some cautionary words for certain medical conditions. We've talked a lot about fluid, and so folks often ask, well, how much am I supposed to drink? So what I usually tell them is, you should drink at least a quart of water a day. All fluids are not equal. If a coffee cup never leaves your hand, and don't look at my coffee cup, make sure that you still drink enough water. The caffeinated beverages have other effects that are not particularly good for constipation. They don't cause constipation per se, but because they make you urinate more, there's less fluid available to the gut. So congestive heart failure is then the tale of caution. nobody is asked to restrict their fluids to less than a quart a day. So a quart is fairly safe for everybody, even those with congestive heart failure. But if you do have that condition, you must consult with your doctor.
So that's 4 glasses.
That is 4 glasses. But what I usually find is, and I don't know, Cavetta, if you've noticed the same, that people are not drinking a quart of water a day. So we can't emphasize enough the importance of water. And, you know, many times folks will say, well, I just simply don't remember how much water I drink. I drink a glass with each meal, but, you know, maybe sometimes I don't. So the simple answer to that is, if you have a quart pitcher, set it in your fridge or set it outside, whatever temperature you prefer your water to be, finish it every day. It's just a matter of creating that discipline, just like we say portion size. So there is size for water too. So at least a quart is good, even if you have congestive heart failure. And I really mean water. I don't mean juice. I know that people grew up drinking juice. It doesn't have too much to recommend it, frankly. It's loaded with calories, and you can only drink so much juice. You can't drink 4 glasses of orange juice, but you can drink 4 glasses of water. I don't think anybody drinks that kind of juice anymore, but you know, certainly water is very important. The second caveat is, as you mentioned, Cavetta, about those taking opioids. So if you're going to have elective orthopedic surgery, and the commonest one for us here would be joint replacements, they're planned. So when those are planned, you know, usually prior to that surgery, there's a pre-op evaluation. And I think that it would be a good idea for us, and I'm not sure we always do it, to speak to folks and say, well, you know, one of the things that's going to happen post-operatively, it's very likely you'll be anemic, because that almost invariably happens, but that you may also have some constipation. Be attentive to it, and ensure that they've got stool softeners or laxatives or whatever it is that they need to take before it becomes a problem. We don't want to wait for the problem to occur. We want to be preemptive when we know that there's planned orthopedic surgery, so that post-operatively that can be addressed. Okay? And we already spoke about opioids. So anybody who's taking opioids for a chronic condition, now those opioids, as the community well knows, now no longer come from, for those who are in independent living, they don't come from the medical center. They come to you from prescriptions written at the Pain and Spine Center or some pain management facility. So
you have stopped altogether giving opioids?
Except in Garden Ridge, when there's a single order pharmacy, and that is really to comply with Virginia's legislation to address the opioid epidemic. It is now a requirement that before a patient gets an opioid prescription filled, and every time it has to be refilled, they have to be seen by a physician, and there's mandatory urine testing. And so it's a detailed process which the medical center is not equipped to do. So from independent living, we have the pain management facilities address that. At Garden Ridge, we are able to do it to a degree in rehab, and that is because there's a single pharmacy. We don't have multiple pharmacies. The problem with opioids comes in when a person has a prescription which can go to multiple pharmacies, and they can get too much of opioids. So if there's a single order pharmacy, you know that the person is only getting the medicines that are prescribed right from there, and there's no other opioids coming in, so it's easier to handle it.
Okay. Sorry, I didn't mean to get off on that tangent, but I think it's an important one.
Of course. And then, of course, we already spoke about iron therapy. Now, let me say a couple words about iron. Again, this is modestly tangential, but important, and maybe we'll talk about this another time. Iron deficiency. You don't have to be anemic in order to have iron deficiency. So iron deficiency is rather common. It's associated with protein manifestations, which can be weakness, not enough strength, leg cramps, and a multitude of symptoms which are so broad and diffuse that if you said to me, this is the symptom I'm having, I would say, oh, it's iron deficiency. I couldn't say that. But the reason I mention this is many times people don't want to take iron, and one of the reasons is because it causes constipation. So if you have been prescribed iron or you're iron deficient, please don't turn your back on that iron, literally. You need to take it, and the constipation that goes with it can be mitigated again with some of the measures that we've spoken about. So while iron may cause that, it is an important medication to take. It is not a supplement that you take because you want to. It's one that you may need to because your body needs it. So it's one that we have to be particularly attentive to. So I think maybe then we should move on and talk about, what are folks going to do at home? What are we going to do by the way of over-the-counter drugs, stool softeners, laxatives? Do you want to?
Sure. Sure. So if you're someone that prefers to go a more natural route, then I would definitely, if you are having some constipation at home and want to start solving a problem. If you want to go the natural route, I would definitely start with prunes and or prune juice. You can warm it a little bit. That actually makes a big difference.
How much?
Just a glass. Try a glass in the morning, or if you want to actually eat prunes, you can try 2 or 3 prunes at a time and see if that helps. And again, you can also up your fiber intake too. But if you're actually having the problem immediately, I would definitely try the prune juice. From there, if you want to go to the drugstore and start getting some things, I would start with something gentle like a Colace. And again, I'm not promoting any particular medication, but these are just some that you will see on the shelf. So that when you go in there, you'll know what to reach for and kind of have an idea of what will help you. Colace is a pretty mild one. Basically, it works by helping to gather more water to the stool itself to make it easier to pass. If it's been going on for a few days and you really feel like it's time to make things happen, then I would move on to your actual laxatives, something like a Miralax, something like a Senna. There is also a preparation out there that has Senna mixed with Colace, which is actually one of my favorites, that you could use as well. And they work pretty quickly. Like if you don't see a result by the end of the day, then you know that you need to continue to take it.
You have to be kind of careful of those in terms of getting too much, or? You
do. If you're going to take Miralax, I would just take it once in the day and wait. I wouldn't take it again. I would just try it once. Because again, and so proper laxatives, your Senna, your Miralaxes, your lactuloses, those work by drawing fluid in from the tissues into the colon, and also by increasing that muscle action that helps to move it out. And so, yes, if you took too much, you could actually dehydrate yourself a little bit.
Dehydration.
You could.
Sure.
It can happen.
And you can get diarrhea too every now and then.
You could.
Very much so.
Someone, particularly at Garden Ridge, tell me that they've gone from having constipation.
One extreme to the other.
Yeah, one extreme to the other. So
Yes.
certainly some caution is needed.
Yes.
And
I was going to say, and for laxatives, they're not, unless it's just a chronic problem or you have a medical condition associated with it, they're not really meant for daily use. Like I said, if there's a good reason, of course, but if it's just something that you have every now and then I wouldn't necessarily recommend taking it every day, just more when you actually need it. If you want to take something on a daily basis for prevention, I would definitely suggest going back to your fiber, your prunes, or a Colace, something that's more mellow.
Okay.
And that is in keeping with what we continually say about drugs. Polypharmacy is way too common, and whenever we can avoid drugs, we should take them as we need them. So sometimes constipation can become bad enough. You may need to take a suppository, or we might need an enema. Sometimes it can be bad enough where we may have to, that's very rare, that it may require further action, but generally constipation can be alleviated. So
now, who would give a patient an enema?
Folks can take enemas at home.
Oh, they can?
Oh,
okay,
yes,
all right.
yes.
So that they could buy a kit?
Yeah.
All right.
They
Didn't know
definitely
that.
can. Yeah. And there are some, who, because they have chronic constipation, know when to take one. So when should you do what? That brings us full circle to where we started. We said first thing that's important is to know what constipation is So, if you don't have a bowel movement every day, that is not constipation. So less than 3 bowel movements a week, and each person has a different regularity. So if there is a change for you, that might be the exception to that definition. The second thing is to see what can you do for yourself. So this is a matter of creating a discipline for your body, recognizing that you need to watch your fluid intake, drink at least that quart of water a day. That's safe for everybody. Make sure that you have enough fiber. Make sure that you're exercising. None of these are mutually exclusive. All of these put together would prevent constipation from occurring, which can be very uncomfortable. It doesn't have to be dreadful, doesn't have to be associated with nasty complications. It's just uncomfortable. And we want for folks not to be uncomfortable. So recognizing when you need to make a change is really important. When do you need to go get that stool softener if you're not regularly taking it? Take a suppository. And then when should you go to the physician? If you didn't have a bowel movement today, you don't need a physician tomorrow, for sure. So it's when you have chronic constipation, which is going on over a period of weeks and months, and you're not able to deal with it, you need to see a physician. And what the physician, or should I say licensed independent practitioners, because that's the way the legislation is going, and it'll be in Virginia also soon. Don't know the timeline, but it's going to happen. Is when you need to go see someone to advise you further on how to modify that, so that we can prevent this from being a chronic condition for you and get your body to follow this discipline. Drink your water, eat your fiber, eat your prunes, make sure you walk, and then if you need additional help, we'll help you figure out what works best for you.
Well, I think this has been enormously helpful to, I'm sure, many people, probably most people, at some point in their lives are facing this issue. I think that's probably, I see that we're down to the last minute or so. Is there anything you'd like to leave us with in terms of thoughts? I think you really concluded here.
No, I think that pretty much sums it up. When you know you're having a problem, address it yourself, work with it, and then if it doesn't work, come and see a nurse practitioner or a physician and let us help you with it.
All right. I think that sounds like perfectly reasonable advice. Thank you both so much.
Thank you.
Sure, thank you, Marcia.